So you're all very welcome to part one, Human Factors, A Journey of Discovery. This is the first webinar in our three-part series, A System Approach to Insulin Safety in Community Pharmacy. The Pharmacy Forum and the Strategic Planning and Performance Group of the Department of Health, which will hereafter be abbreviated to SPPG for tonight, we've been working in partnership. And whilst we do work collaboratively on a whole lot of issues, this is the first co-produced event, I do believe anyway. So my colleagues on the working group, I must introduce them as well. It's Matthew Dolan, who is the pharmacy coordinator at SPPG, and Angela Carrington, the lead pharmacist for medication safety at Health and Social Care in Northern Ireland. Jane Keenan, who is the project manager at Regional Safer Medicines, and Fanula Walsh, project support officer at Regional Safer Medicines as well. I also at this stage want to thank Sharon Bell, who has been sending you all your information about tonight and is coordinating the Zoom this evening. And on that note, if you drop out, Sharon will sort of rejoin you. So don't be afraid to come back in if you disappear or your internet goes down at some point during the evening. So I would also like to welcome Professor Paul Bowie and Dr. Helen Vosper, who are guest speakers for tonight, but you'll hear a little bit more about them later on. But thank you very much for joining us this evening. And it's our hope that we'll very much create a fresh perspective tonight for you as we explore human factors and how they can be applied to support patient safety and also the well-being of the pharmacy team. So very importantly for everyone out there who participates in CPD, all the slides will be available afterwards, so you don't need to scribble as you go. We'll get those out to you to download in the next day or two, along with a few other resources, I believe, as well. So without further ado, as they say, we'll just get started because I'm sure you want to hear from the experts and not from me. So to start our event and set it in a little bit of context, we've also invited Fiona Kirkpatrick along tonight, and she's the Senior Principal Officer at the Department of Health. And tonight she's representing Kathy Harrison, who had to send her apologies because she had another event tonight. So we're just, Fiona is going to sort of set the context for us for this work in the wider Northern Ireland Medication Safety Collaboration Programme. So Fiona, if you just want to join us there on your mic, that's great.
Okay, thank you, Julie. Thanks everybody. And I promise I will be quite brief because I'm sure you want to get on to hear the detail from Helen and Paul. But as Julie said, my name's Fiona. I'm a pharmacist within the Medicines Policy Branch at the Department of Health, and I am delighted to be here this evening on behalf of our Chief Pharmaceutical Officer, Kathy Harrison, to open this event series, which, as you'll know, is focusing on a systematic approach to insulin safety in community pharmacy. I suppose as many of you will be aware, this initiative links with the wider agenda of transforming medication safety within Northern Ireland. And it was approximately 2 years ago, our Health Minister, Robin Swan, launched the Department of Health's Transforming Medication Safety in Northern Ireland plan. And our strategic plan was published in response to the World Health Organization's challenge, Medication Without Harm. And I'm sure many of you will be aware, the goal of that WHO challenge is to reduce severe avoidable medication-related harm by 50% in the next 5 years. And so the Northern Ireland strategy really describes the key priorities that will enable this to happen, and it focuses on 3 priority areas, being high-risk situations, polypharmacy, and transitions of care. And within that, there's specific programmes of action for improving medication safety across 4 domains of health and social care staff, patients and the public, systems and practice, and medicines. And it really is very much an ambitious programme, but incredibly important programme to improve safe practices with medicines and embed a medication safety culture within our population. I suppose the plan, as many of you have probably seen it before, the plan is clearly illustrated in the Transforming Medication Safety wheel within the strategy, and as can be seen from this evening's imagery, some of it was on the screen there already. So the focus tonight is on a particular quadrant of medicines, and in particular high-risk medicines, and we're all acutely aware of the risks that come with all aspects of insulin use. And it is only with a systematic approach, so including networking, co-production, which has already been mentioned this evening, and the application of human factor principles that then we can make significant improvements in medication safety, and in particular, I suppose, reduce that preventable harm from insulin. So I suppose just really to congratulate SPPG and the Pharmacy Forum on their collaboration to create this informative series. It really is fantastic to have, and delighted to have input from experts in each field across the series. And I suppose just finally to thank everybody who's given up their evening after, I'm sure, an incredibly busy day at work. But I suppose we've said it many things before, we do all have a role to play in medication safety, so it really is great to see that commitment from so many of the pharmacy team here tonight. So yeah, just to say thank you very much, and I hope you enjoy the evening. Thanks, Julie.
So hi, thanks Fiona. So I'm Angela Carrington. I'm the Northern Ireland lead pharmacist for medication safety. So thanks for Fiona for setting the context for tonight's start of our webinar series. And human factors is incredibly important to transform medication safety in Northern Ireland. It is a scientific discipline which equips us with those skills to understand work systems better. So it's with great delight that we have Professor Paul Boy and Dr. Helen Vosper helping us on this journey, and they're going to share their human factors expertise and insights. They're both nationally and internationally renowned chartered ergonomists and human factors specialists with various roles in academia, NHS leadership, and also working within the healthcare safety investigation branch. So tonight, Paul and Helen are really going to provide us with an introduction to human factors, and we will progress this as we go through the webinar series in our next events with the focus on insulin safety. But we need to get that sort of awareness of what this is and the concepts and the principles and tools. So this will be very much an interactive session. So plenty of opportunity to ask questions, raise your hand, post something in the chat. My position always is there's no such thing as a stupid question. So everyone else will probably be thinking the same thing. So feel free to ask away. And there will also be opportunity at the end for any mop-up of Q&A. So I'm going to now hand over to Paul and Helen. So thank you very much.
Thank you very much indeed, Angela and team, and thanks very much for the invitation to come along this evening to speak to you about human factors as part one in the series. I will do the technical bit if you don't mind. So good evening, everybody. Bear with me. I think I got there. Yes, well, just to kick off, I'll probably say a bit more by myself and then invite Helen to say, so you've got a better context of what it is we do. So I'm Paul Billy. I've worked in the NHS for over 30 years. I'm a non-clinician, but as Angela said, I've got one of these trendy portfolio careers where I work for NHS Education for Scotland as Programme Director for Safety and Improvement. I work across multidisciplinary teams, including with pharmacists and others. But I also work in academia and also do some sessions with the Healthcare Safety Investigation Branch in England. Helen, do you want to say something briefly about yourself, please?
Sure, thanks, Paul. Welcome, everybody. It's great to be here. At the moment, currently, I'm the patient safety lead in the medical school at Aberdeen University, but I came over to the dark side from Robert Gordon University, where I spent 16 years teaching pharmacology and therapeutics and human factors on the undergraduate Master of Pharmacy course. So I've got a great deal of interest in pharmacy. I also work as a scientific advisor to NHS Education for Scotland in human factors. And as Angela said, involved on the education side at Healthcare Safety Investigation Branch, and we see these insulin errors over and over. So in fact, at the moment, I'm working on one currently that we had up at Forester Hill in Aberdeen. So this is very much of interest to us as well in the more specific as well as the general aspects of it. Thank you.
Thank you very much, Helen. So Helen and I are just going to segue our way through some of these slides, and we'll hopefully raise awareness of what is meant by human factors and explain its value from a system safety and workforce wellbeing perspective. We're going to ask you to interact as best as possible. You don't necessarily have to put your hand up, but if you do, we'll be delighted to answer any questions you have at any point. As Angela said, there's no silly questions. But one of the things we will be asking you to do is to think through from a systemic point of view, and we'll explain what we mean by that, what you see as priority design and safety challenges in your own workplace, We did this at a GP conference a few weeks ago. What seemed to work quite well, and we ended up theming some of the issues that were identified by GP team colleagues as well. So hopefully we can do something similar tonight, and Helen and I will do a short report on that and feed it back to you. I suppose the most important thing is that there are a range of practical human factors tools and concepts and approaches that anybody in healthcare can pick up and hit the ground running with, especially from a system safety point of view, and we'll signpost you to them tonight. When we go through the series, so parts 2 and 3, obviously we're going to focus much more and more in depth about human factors and a human factors approach known as the SEEP framework, which we'll explain. And also, obviously, we're going to focus much more on insulin safety, as Helen has said. I mean, that's the overarching purpose here. But this session tonight is purely foundational about human factors and its role in terms of how it can enhance both system safety and human well-being. So just to kick off then, the first bit of interaction. I know you've been busy all day, you're tired, but if you could actually put your fingertips in the keyboards, post some comments. What comes to mind? Okay, what do you understand by these terms, human factors and ergonomics? I'm just going to give you a minute or so to re-engage your mind, your brain, get it working again. And then just whatever comes to mind, what do you associate with these terms? Or even have a guesstimate at how you would define them? Even one word? Distractions, thanks, Paddy. Things that influence behaviour at work, excellent, Tracy, yeah. I was about to speak too soon there. I said nobody's ever failed, never to post a comment on this before, but thank goodness they're coming in now. Rushing, Loretto, that's interesting, yeah. Pace of work. Workflow again, thanks, Eunice. Yeah, so human factors includes both patients and staff, and that's a really important point that's made there. Being on autopilot, Alan's saying, so there's a fancy term for that as well. Training, skills, capability, dispensary design, okay, so similar packaging, the environment, removing hazards, right? These are all excellent suggestions. So human factors is really focused in everything that as you'll see, everything that you've highlighted there. So anything essentially that's to do with human work and both risks to human work and how it's designed and how we operate on a daily basis and how it can impact on both our performance and our own well-being and that of our patients and families and carers as well. What people contribute to a process, thanks Julie, and storage. So that could be about standardization and simplification. And, you know, when I visit a pharmacy, I tend to see excellent practice in that regard. Hopefully you'll verify that or maybe not. So these are all brilliant contributions. So thanks very much indeed. So bear that in mind as we start to unpack what we actually mean by human factors and ergonomics. I seem to have lost the buttons to advance the slides. Here we go. Okay, so what we have here is a kind of really fancy academic definition of human factors. So the standard dry definition of what we mean by human factors and ergonomics. And to start to unpack that a bit, perhaps the first thing to realise is that human factors and ergonomics are synonymous with each other. Okay, so depending on what part of the world you were brought up in, there's typically a preference for one term over the other. So in North America, it tends to be human factors, and the rest of the world, it tends to be ergonomics. I'm speaking in very general terms, but what happens is that professional societies tend to adopt both terms just to keep everybody happy. But they are essentially the same scientific discipline and the same profession and the same practice as such. So that's maybe the first thing that you can boast about when you go back to the workplace, that ergonomics and human factors are the same discipline. In terms of breaking down what it's about, you can see there it's about understanding of interactions among humans and other elements of a system. And you picked up on quite a lot of those interactions, those issues the impact on well-being and performance. An important point there is, and this is something I hear quite often in healthcare, is that to distinguish here is that humans and other elements of a system. The implication there is that humans are part of a system, and that's the human factors approach. Humans are core, they're central to all system activity. But what I hear often when I speak to clinicians is, oh, it's a system problem, oh, it's a system issue, as if the system is something abstract over there and it's divorced from them. So, human factors views it completely differently. You're central to all care processes and all care systems as such. Even though you may not be in a position necessarily to influence it, you are still significantly part of it in terms of interaction and interrelationships as well. We have the purpose of human factors there, and this is one of the distinguishing features which we'll touch on in a minute. So the purpose of human factors is to jointly optimize both human well-being and system performance. So, because we believe you can't get one without the other. Okay, so you can have the best safety checklist, the best standard operating procedure in the world. Okay, but if it's impacting on your ability to do your work, okay, so it could be the best design checklist or procedure, but if it takes you 5 minutes longer to do it, and when you're using it, and it's impacting on your well-being in some way, it's causing you a frustration and irritation, so it won't be sustained. So you need to have an equitable balance there in terms of addressing well-being issues as well as performance issues. And that is a significant distinguishing feature of human factors, which, as we'll see, is a different approach from what happens generally in patient safety and quality improvement and so on. But in order to simplify all of this, so we have to sell a message about, an accessible message about what human factors is about. The easiest thing to say is it's for designing for people to make things easier, usable and safer, to make it easier for them to do the right thing and harder to do the wrong thing. Okay, that's probably in a nutshell the most accessible definition of what human factors is trying to achieve. So I mentioned those distinguishing features, and what you're going to hopefully learn about tonight is the whole idea of taking a systems approach, and that's known as the SEEPS diagram, and we'll explain that in due course, and you'll get a big dose of it again in a month, and we'll devote a full session to it. It's always design driven. This is another characteristic of human factors. So Helen and I learn a lot about design principles, interaction design, inclusive design, participatory design, international design standards, about how you fit the human to a task and not the other way around. And so we know a lot about the human characteristics, needs, capabilities, and preferences of people. And these are really important in order to design workplaces. But it's something that's often overlooked, or at least has a limited application in healthcare. And I mentioned those twin aims. The twin aims of human factors about jointly optimizing system performance and human well-being. And by system performance, we mean safety, we mean productivity, efficiency, effectiveness. And by well-being, we mean your health and safety, we mean your experience, your comfort, your satisfaction, your joy, and that applies to patients and carers and families as well as the workforce, so we don't distinguish there. I won't break down that model just now because Helen will do that later on. And so there are lots of people in healthcare who have a role in improving human work, including yourselves as sharp-end practitioners. But those distinguishing features that I've just outlined are what human factors professionals bring to the party, that the other professions don't necessarily take that approach or have awareness and knowledge of some of the related concepts and international standards that we can apply to problem solving and to design and to improvement activity. And so the underlying science, so excuse my language here, but human factors is a bit of a mongrel, a bit of a bastard science in that sense. We take and we steal shamelessly from other science disciplines. And so we use their knowledge and to apply it to the human-centered design of tasks and work systems and products and buildings and so on. And so we have a strong interest in anatomy and anthropometrics and psychology and interaction design and user experience. So a science like anthropometrics, which is the science of body measurement, became really important at the outset of the pandemic, when we found that PPE was, apart from short supply and often of poor quality, was often designed for men and not for females. And so there was a lack of human factors thinking, lack of application of anthropometric principles and measurements in the design of that. And we still see that in lots of places in healthcare. So for example, if you look at an operating theatre and surgical instruments, you will see that many handheld surgical instruments are designed for men and not for females. And so they often have difficulty in grasping and using some of the technology, which has an added effect in terms of the potential for error, but also in the physical impacts that in musculoskeletal injuries that can be acquired as a result of using technologies and tools that are not designed for human fit in that regard. And so we apply these science principles to the human-centered design of these particular issues in the centre here to try and get these twin aims that we spoke about earlier on. So in healthcare, there's been a strong interest for decades. WHO, European Union, all our departments of health, our royal colleges, the government, a strong interest in human factors, but very, very little in terms of policy and resource being applied to try and build capacity and capability in the workforce. So we do see lots of examples of human factors approaches being applied in healthcare. And here are a number of areas where there's been multiple studies of the importance of human factors in, for example, medical design and usability, design of the built environment. A big area that's just coming in just now is artificial intelligence and the human factors approach to that, digital design and IT, the prevailing safety culture. Helen and I have done a lot of work in that area over the years. But it tends to be from a research and innovation and development point of view rather than routine practice. So we do our best to try and get into routine practice, but because of the limited numbers, as we shall see, of human factors practitioners, it can be quite a hard sell in that regard, although there is strong interest, as I said, across healthcare and across the different professions in this approach. So there's a single principle here of many from a human factors point of view that we just want to get out there quite quickly. So the discipline itself promotes a fundamental rejection of the idea that humans are primarily at fault when making so-called errors in the use of a complex socio-technical system. So complex socio-technical system is just a fancy academic term for any type of healthcare workplace. So a community pharmacy, any type of pharmacy would be seen as a complex socio-technical system from the human factors perspective. So when somebody makes a mistake in that, our automatic position is that it is a design issue, a work system design issue. So if you arrive at the conclusion that somebody's made an error here, then to us, that's the beginning of the learning process and not the end point of it. It's not the conclusion. We have to explore the systemic issues that gave rise to that error in the first place. And that's a foundational human factors principle, and we never deviate from that. So a colleague of Helen and I's, Sue Hignett, has kind of summarised human factors principles around these terms here. So can this person, and that person could be somebody as a member of the workforce or a patient or a family member, with training or information, do these tasks using this equipment or service to these standards? So can they meet a performance under these conditions? So working within a certain physical environment or under certain climatic conditions as such. So that kind of, to us, summarises it in a nutshell, and we're grateful for Sue for, taking a 360-page textbook and summarising it in a couple of sentences. But that gives you a flavour, hopefully, of what the human factors perspective is in this regard in terms of trying to understand and improve workplace safety and the well-being of those who work there. And so another sense check, be good if you could post in the chat or feel free to put your hand up. So you've posted some comments at the beginning. Now that you can reflect, hopefully, and having a bit more information and knowledge around what human factors is, how does this compare, do you think, with what you initially understood with what human factors was about? Is it somewhat different, much the same, radically different? So it'd be good to hear, just if you want to post some comments in the chat, or as I say, if somebody wants to put their hand up, put their head above the parapet, feel free to do so. Yeah, so Anne's posted a good comment there. Yep, that, a bit less blame orientated, and that's a significant human factors approach. and we always focus on that systems element as well. Yeah, so complexity. So, you know, if I was being slightly facetious, we always have a bit of rivalry with our quality improvement colleagues. I would say that from a quality improvement perspective, complexity is its Achilles heel. Quite often the way they approach problem solving tends to be much more simple and complicated rather than hugely complex, which I think human factors is better suited, but the two of them can work in tandem, and that's the good thing about it. So Loreto's saying, yep, it's all back to systems. There's lots of additional factors and not just about human error. Yeah, that's a good point, Tracy. Yeah, so just to tease out the point that Tracy's made there, so you thought it was much more about safety. So if you think about any aspect of human work, okay, so anything that irritates, frustrates you, anything that can go wrong, anything that's poorly designed, and that could be a standard operating procedure, a piece of kit, the physical environment in which you work. It could be a team working issue, a communication issue. So any issue that impacts on those twin aims that we outlined is seen as a human factors issue. So essentially, human factors is about every aspect of human work, and that does include safety, because healthcare is a safety critical activity, and pharmacists are at the real sharp end of that. But there's also other outcomes that we're looking for. So patient experience, staff experience and well-being, productivity and efficiency. So human factors has got a lot to say in all these different areas, not just in safety, but clearly from an NHS point of view, safety is such a huge priority. So just to give you a quick sense check about, a reality check, human factors is well established largely through regulation in other safety critical industries. So nuclear, in the military, in aviation, in the offshore industries. So it's just seamlessly integrated within a lot of what they do there. And so we look at aviation. So there's an organization known as Eurocontrol. They control this. So when you go on your summer holidays in Europe, they control the skies and pass you from country to country, air traffic control to air traffic control. Now they employ about 7,500 folks. And they also employ around 40 human factors safety science specialists. In the NHS in the UK, we have upwards of 1.3 million employees, and at the last count, we probably had less than 10 human factors specialists employed specifically because of our human factors specialists. And Helen and I don't count in that regard, even though we kind of tend to work with the NHS because we're background staff. What we mean by that is there's very few folks embedded in frontline clinical practice alongside the teams that you work in, whether it's in primary care or whether it's in the hospital side as well. So we've got a significant need to build capacity and capability, and I think that's well recognised, but a long way from getting there just now. So it's just to give you that background context. So we have to think creatively, we have to think smartly about different ways we can build capacity and capability, and this is one of them. It's not the overall answer to it, but we already know that it does work by giving those at the front line in practice some foundational knowledge and approaches and tools that they can apply to their everyday work and get some success with. I won't labour this too much. This is much more for colleagues who work in the simulation world, who work in the education world in general, who work in surgery, who work in anaesthetics, where human factors, in inverted commas, tends to be embedded a lot more, and a lot more is known about it. But it's unfortunate that there's lots of myths and misunderstandings in that regard. So, Helen and I spend probably a significant minority of our time and energy, asking people to rethink and unlearn what it is they think they know about human factors because of the way it was introduced to healthcare. And I won't go into these in any detail, but it's not about eliminating human error. It's about designing work systems to be more resilient to human error. It's not about modifying people's behaviours. That's something that psychology does or education does. It's about modifying the design of the work system to make it easier for you to do the right thing. And it's not just focusing on individuals, as you can see. It's system-wide. We are interested in all problems across the system because people interact with every aspect of the system. And so, very briefly, these are some of the the issues in which human factors is conflated and confused with. So it's not about factors of the humans, it's not a cause of failure, it's not team training or non-technical skills, and it's not simulation as such. So to say, I won't go into that too much. So the two dual approaches from a human factors point of view are the systems approach and focusing on design. Okay, and I'll pass you over to Helen now, who'll start to unpack that a little bit. Thanks, Helen.
Brilliant. Thanks, Paul. If you could just give me the next slide, please, that'd be great. So it's interesting that I think it was Ennis mentioned analytical, and I think that's actually a really good point. That what we're thinking about in terms of human factors is exactly that, is about being analytical and taking a systematic approach and actually gathering empirical data about what goes on in systems, so that any improvement that we make can be genuinely informed by data. So the system is the level of analysis, if you like, in a human factors approach. And system, unfortunately, I think is a term that's used almost ubiquitously. That, along with strategy, are probably the two most commonly used words that people don't necessarily really have a good shared understanding of what they mean. So it's worth just spending a little bit of time thinking about how we can define a system. And I would say, sort of in its simplest terms, essentially it's just a set of entities or components that are kind of engaged in the same aiming, a set of entities united in a sort of common purpose, if you like, for a particular outcome. But systems can be really big or they can be really small. And very often the problem is that systems sit inside other systems. So you tend to get nesting, which can make it quite difficult to actually unpack parts of the system. So one of the things that you need to do is you need to identify what the purpose or purposes of a system are, and you need to put some sort of boundary around it. So it doesn't matter if you look at a big bit or a small bit, you've just got to be clear which bit you're actually looking at, so that other people who then come afterwards can see what you looked at and what you didn't look at. But systems can be as small as a person doing a task, so like making a cup of coffee, because you don't do that independently of other factors like the environment in which it happens and the organization in which it happens. So even though it's a task, it is a system in itself. But you can go, we've got a list on here of all possible systems, but going right up to the top, so the macro level, the big systems, is actually the NHS itself, or organisations within the NHS. Next slide, please, Paul. So we have to decide what our system is, and then we have to explore that system. Now, one of the problems as well that works against us is that we're human beings, and as you'll remember from when you were at university too, we are run by our autonomic nervous systems, particularly the sympathetic nervous system. So we're not actually very well designed for systems thinking. That sympathetic nervous system reduces complexity to kind of simple linearity in order to deal with the crocodile nearest the canoe. And as we all know, in healthcare at the moment, there are a lot of crocodiles and they're all very near to the canoes. So in order to explore the system and to make sure that we do it properly, we tend to use a systems framework. And I'm going to talk about a couple here, but I'm going to start by talking about the Systems Engineering Initiative for Patient Safety. Excuse me, I'm just going to have to call. Sorry, this cough has been getting worse over the week. I'm just having been back with a lot of students. I'm just wondering, is it a cold or is it actually something worse? So sorry if my voice gives out after a bit. But the Systems Engineering Initiative for Patient Safety is a systems framework that was designed, as it sounds like, was actually designed for healthcare. And certainly from a research point of view, it's been well tested. But increasingly, we're recognizing that this is actually quite a good way of explaining systems to people. And it certainly seems to be something that's very useful for helping people develop that systems awareness, if you like. So I'll start off by explaining this model just briefly. And as I say, we'll unpack that in much more detail in the later sessions, where this is the framework that you'll use for looking at your insulin safety. So if we look at that SEEPS model on the right-hand side of it, we have outcomes. And we're generally sort of fairly good with outcomes in the sense that we think we understand outcomes, and we certainly talk in terms of outcomes, and we reward and we punish in terms of outcomes. So we think about targets and then how we deal with that if those targets aren't met. But as some of you mentioned before, we tend to think of human factors being about safety. It's not, it's about all the system outcomes. And it is important that we consider them together, because very often those outcomes will be competing. And certainly it's one of the issues with taking human factors approaches in healthcare, is that the spend on it might be quite high at the beginning, although down the line it might bring significant rewards. But you're balancing that initial cost against all the other things that the system needs to manage. So we're trying to think about all our outcomes together. And it's processes that deliver those outcomes, but not just the care processes, remember, everything else that goes on in the background and keeps the show on the road. So when you're thinking about an adverse event like an insulin error, you tend to work that way around, don't you? You've got an outcome, you think about the processes that led to the outcome, and very often that's as far as you get. But the reality is those processes happen within a very specific work system, and that's the left-hand side of the system, and that's the bit that we don't look at that often normally when we're investigating adverse events. So the work system just contains all those entities that we mentioned, so the people, the tasks they do, and the tools and technologies that they use to do those tasks. But remember, they're working in a very specific physical environment, but they're also influenced by an external environment, which goes right up to the kind of policy and legislation level. But you've also got the organizational background. So the organization decides so many of the other system entities, it decides who it employs, it decides its workload matrices, all those kind of things. And all of these are going to influence how those work processes are delivered. And then the way SEEPS looks at it, it's a Donabedian model, basically an input process output model. And what it's saying is that when you undertake your work processes, you force interactions between the different system entities. So if you're prescribing, you might interact with the patient, but you might also interact with an electronic medicines management system. And it'll be the nature and quality of those interactions that determines how successful or otherwise the outcomes are. And when you do a systems analysis, what you're trying to do is you're trying to identify key interactions. So there'll be millions in any complex system. And you're trying to identify the ones that are most important, both in terms of good outcomes and bad outcomes. Because what you want to do is you want to redesign your system to design out the bad bits, but to keep the good bits. And if you're not aware of the good bits, you can inadvertently end up designing those out. So key issue there is interactions. Now, it is important to mention that SEEPS isn't the only systems framework, but really all you're looking for is something that takes your gaze away from the front line and lifts it up and out to help you think about all of the factors that might have contributed to an incident. On the left there, we have the onion model, and essentially you can see it's saying the same things, that the people doing these tasks and interacting with their equipment all happens within a broader context. And key in the onion model as well is the interaction between the different layers in the onion. So those are the key points, and that's the thing to take forward with you from this, is that when you do work, you force interactions between the system entities, and it's those interactions we're trying to understand. So that's the systems approach. Next slide, please, Paul. Now, so we said it's a design-based systems approach, and what we're saying is that if we understand our system properly, we can then take steps to redesign the system. So we need to understand really what we actually mean by design, because it'd be interesting to get your thoughts as we go through the session about how you think of design in terms of how that might influence your work. But essentially, human factors could just be described as the science of work. And of course, workers use tools. So ergonomics and human factors is very much concerned with the design of tools. But as we've already said, you use those tools within very specific contexts. So by extension, we're also talking about the design of the whole environment and of the artifacts that we use. So implicit to everything that happens in human factors is this idea of user-centered design. And I really like this definition. I don't worry too much normally about definitions because you can kind of get tied up in those. But again, this is back to what Ennis said about analytical. If something's intended for human use, then its design should be based on the physical and mental characteristics of its human users, in so much as these may be determined by the investigative methods of the empirical sciences. So all it's saying is, don't base it on what you think people need. You need to actually get into your work system and understand exactly what the people in the system need. Next slide, please, Paul. So what we're trying to do is make sure that everything we design, whether it's a tool or technology, whether it's a work process, whether it's the environment or the whole system, what we're trying to do is make sure that we fit the job to the worker and the product to the user, not the other way around, which is unfortunately too much what we do, particularly in healthcare. We bring people in, they're all very different, and we expect them to cope with a system that's not really designed for them. Next slide, please. Now, I like this as well in thinking about what design actually means to us in that sort of systems context. It's actually, some ways, it's better to think of what happens when you don't design for the users within a system. And very often we don't do that. You would be surprised at how much design is actually influenced by the designer themselves. So if you've done a good design course, you might well have done something around human factors, but not necessarily. And people very often design on the basis, well, if it works for me, I'm an average person, so it should be all right. Or they think about designing for an average person and think, and that'll be okay for everyone else, but don't necessarily have an understanding of the variability you get within the population. Or probably even worse is recognizing that people have different needs. But saying, well, I can't really cater for all of those things, but they'll manage, won't they? And I think that's what we do in healthcare. We either don't think about it at all, or we rely on the fact that the people in our work systems can actually cope. Because the reality is they probably will cope for quite a long time. I mean, if you just think about something like musculoskeletal injuries, you can pick the same heavy box up day in, day out for 20 years, and it'll be on you 20 years and one day that intervertebral disc pops and you end up with a problem. So people cope for a very long time, and we rely on that when we don't actually take user needs into account. This fourth fallacy is an interesting one as well. It says actually thinking about human factors is expensive, and most people are interested in styling. And I have to admit that I think this one might actually be true. That picture of the kettle there, that's an Alessi kettle, and I've coveted this kettle for decades. It's hideously expensive. Now, when I was on my human factors master's course, we had to do a piece around user-centered design, and the piece of equipment I got was a walk-in frame, but somebody else got to do a kettle. And what they did was they compared and contrasted two kettles, and one was this lovely Alessi kettle, and the other was a really cheap, crappy little plastic kettle that they'd got out of the travel lodge. And on absolutely every performance measure, the crappy little kettle absolutely kicked the backside out of the Alessi kettle. But at the end, we were asked, knowing all that, which kettle would we still buy? And we all chose the Alessi kettle. So there might be some truth in the styling bit. However, that probably doesn't work so well in healthcare. And then this last one is definitely something we want to flag up to you, because you will come across this an awful lot in healthcare, human factors in inverted commas. People say that human factors is just common sense. And we would say that if it is common sense, then there's precious little common sense around. It isn't common sense. What is common sense to one person is complete news to somebody else. And what we're trying to do in taking a systems approach is understand everyone's perspectives so that we can all share that same sense making. Next slide, please. Now, the problem is with those approaches to design is that what you see is that we don't very often test things like pieces of equipment or processes. And if we do test them, we very often don't test them with a representative group. And certainly, I don't know, you may remember, because it did make it into the news, that Ford were having problems with their designers all being like in their early 20s, generally being male and being very fit and healthy, and struggled with designing cars for people that didn't really fall into that bracket. So they worked with Loughborough University to design a suit that actually forced disability on the designers, so they could understand what it was like to live as an old person for a day. And that was what was behind the design of the Ford Focus. The Ford Focus is actually designed for the older user, although they don't actually tell you that when they sell it. And the reason why that sort of thing is important is if that you are weaker or less able, then you can be shut out of things completely, because you might not have the capabilities to be able to access them. Now, sometimes I've seen human factors described as, you know, in a bit derisory way, saying, oh, it's just a collection of stunning glimpses of the obvious. But what we're saying is one person's stunning glimpse of the obvious is completely not obvious to somebody else. And if we take that systems framework, what we're trying to do is kind of share those stunning glimpses of the obvious so we can all see the same things. If we think about designing for the average person, what really do we mean by the average person? So I'd be interested in you popping your thoughts in the chat. Would we design a door to accommodate average height and width? Or feel free to unmute if you'd rather talk about it. Would it be reasonable to design a door based on average height and width? Very quiet. Definitely not. Loretto says definitely not. No need to think big picture. Okay, well, how big? I'll exclude outliers. Depends on who's using the door. Now we go for maximum rather than average. Excellent. Next slide, please, Paul. If you just click, I think the next, perfect, leave it there. That's great. Thank you. So you've all said loads of things there that are really important. So you've said, first of all, depends on who's using the door. Yeah, absolutely. Whenever you think about the design of anything, you need to think about who your users are. So you need to know who it is you're actually designing for. When you think about something like a door, you have to think about its function. So absolutely, it's about access, isn't it? But it also has a very important safety function. If there was any sort of emergency, everybody would need to get out of the door. So you want everyone to be able to get through, but you want everyone to be able to get through, not just in relation to the body measurement. What if they're disabled and they use a wheelchair, so they need to be able to get through? Or what if they're carrying lots of bags? So it's not just the kind of dimensions of the person, it's the dimensions of the person in the context of the task that they'll be doing. Now, it's interesting you say we would exclude outliers or go for maximum. Generally, it's impossible to accommodate absolutely everybody, because if you imagine, there are probably some people who are over 7 foot tall, and you can imagine designing doors would become very problematic. If it's safety critical, what we do is we try to include everybody, but we'll probably go to the 99.99 percentile. Most anthropometric data is normally distributed, so we'll have that bell-shaped curve distribution. But generally, what we think of being inclusive design would be a design for sort of 95% of the population. So most of the time, that's what we're trying to do, is design for inclusion, but sometimes we're actually trying to design for exclusion as well. Don't forget that. So I think with a kid with their head stuck through the gate, ideally you want the gaps on your gate to be too small for a child's head to get through. So you might be designing at the 0.001 percentile. And I was trying to look for a picture that showed this, and I googled child with head stuck in gate, and this picture of the cow with its head stuck under the fence was what came up first, but it made me laugh quite a lot, so we thought we'd include it. But if you are interested in understanding more about exclusion in terms of design, just Google the University of Cambridge exclusion calculator, and it will show you if you change certain characteristics on design, just how many people might be excluded from using a product. Next slide, please, Paul. Now, but the thing I think that's really relevant in relation to exclusion design for unintended exclusion actually does relate as well sometimes to people's medicines. So on the left here, you've got a childproof container. That childproof container, to operate it, you have to push and twist at the same time. And that's actually quite a complex maneuver. And if you have some sort of impairment, perhaps you've got rheumatoid arthritis, operating those containers can be really difficult, and you excluding someone from using the medicine. And these washing tablet boxes. They're supposed to keep children out of there. I think they stop everyone but children from getting into the boxes. So you might be thinking you're designing for safety, but in fact, what you're actually doing is unintendedly excluding people. Next slide, please, Paul. So where there's a very relevant point to this is actually thinking about medication errors that actually arise as a result of packaging. So a case study that we use quite a lot, a healthcare safety investigation branch in the education side, is looking at methotrexate overdose when it's been prescribed as a disease-modifying anti-rheumatic drug and has been prescribed through an electronic medicines management system. And that's to do with the problems that if methotrexate is used as a disease-modifying anti-rheumatic drug, it's prescribed weekly rather than daily. And that's very unusual for a drug. And of course, as you know far better than me, the electronic medicines management systems are set up as a default for daily dosing. But actually, that's not the most common reason for methotrexate overdose in people who are suffering from rheumatoid arthritis. There are quite a few issues that relate to this, but one of the most important ones is at home, patients take methotrexate instead of folic acid. And that's partly to do with the appearance of the tablets. They're all small yellow round tablets. But actually, if you take a human factors approach and you go into people's homes and look at how they use the medicines, people with rheumatoid arthritis struggle with the childproof caps. They can't open them. They are excluded from the medicines. So they work around, which is what often happens in systems. You can't do the job, so rather than doing what you're supposed to do, you do something different. And the patients do that. They decant the medicines. They get someone to decant them into a box, and then the folic acid and methotrexate are just loose and they all look the same. So that unintentional exclusion that we might not have seen if we didn't take the human factors approach is very significant in terms of adverse events. Thanks, Paul. Next slide. And what was interesting was eventually this did get realised and they stopped dispensing methotrexate in the childproof caps and put them into the blister packages. But interestingly, I saw a report just a few months ago, I think it was, in the pharmaceutical journal saying that the elderly people and people with musculoskeletal impairments find it just as hard to get the stuff out of the blister packs as well. Next slide, please, Paul. I think that's back to you now. Thank you.
Thanks very much, Helen. So Helen there has covered, a very high level, two really important human factors approaches. So the idea of the systems approach and the idea of design thinking. Now, related to the systems approach and what sits around it is the whole idea of systems thinking. And this is an area of work that NHS England, NHS Education for Scotland, the Healthcare Safety Investigation Branch are doing joint working on. Because we realise that it's so important that people have the right mindset that they bring to bear in trying to understand safety. So systems thinking is again a foundational human factors approach. So we're trying to understand safety performance. We need to understand these basic principles that go along with it, and we need to buy into them. So I'm going to outline some of these principles. Some of them will be barn door obvious to you. Some of them you've never heard of, and hopefully you think they're of interest. And others you might find a bit challenging. But what we're saying is that together, integrated in a holistic way, these principles form a philosophy or a mindset that people who are interested in improving safety and in learning from when things go wrong, they should be abiding by this approach, because it's arguably much more meaningful in terms of extracting a proper understanding of how and why things have gone wrong, or how safety can be designed into a system, and how you learn and improve as a result of that. So I'm going to go through these principles and just and introduce them to you. We've said before that there's practical approaches and concepts that you can apply immediately to any aspect of your work that hopefully you'll go away with, and we believe that this mindset is one of them. Although it took me a while to get into it, so I appreciate that it can be a hard sell for some, but others intuitively understand it, intuitively get it, and can run with it immediately. So we'll see how we got on with it. please feel free to post comments in the chat, especially if you think some of the principles are particularly interesting or particularly challenging, or maybe even difficult to understand, and that's something we can pick up on. So a foundational systems thinking principle is that we seek multiple perspectives when attempting to understand system safety. Now, I've not got a great deal of experience in that respect within, for example, a community pharmacy, but certainly when I've worked in hospital wards, we will see, for example, maybe the consultant team and the multidisciplinary team maybe working together to try and understand where something's going wrong, or to address a problem that may be related to a safety issue, and then to try and design care processes together as a way to mitigate risks there. And that's good, that's fair, that's fine. But quite often it could be better. They could cast the net wider. So what do I mean by that? So I said, depending on the context, there are people in workplaces, for example, in a hospital, it might be a porter, it might be a ward clerk, it might be one of the domestic staff who actually touch that care system that you're examining. They see it in operation every day, and they see bits of it that you don't see. And they may have some valuable insights that are never tapped into. So they could tell you things that are, where the potential for things to go wrong, or they may have ideas for how things can be improved in parts of the system that you don't routinely see, even though you think you may have designed that system. And so this whole idea of capturing multiple perspectives is a foundational systems thinking principle. And so I don't know whether that applies when you think about it from your own pharmacy perspective. I mean, do you have admin staff, maybe pharmacy technicians that maybe are not routinely involved in team learning meetings from when things go wrong and could be? Maybe they are, and that's wonderful, so that's great to hear. But so it's just to raise awareness that this is such a foundational principle, and it's not well practiced, generally speaking, in large parts of healthcare. This one about avoid blaming is a difficult one, because most people will turn around and say, well, that's barndore obvious. We don't blame our colleagues. We try to be fair and understanding and supportive. We try and take the systems approach, which is another foundational principle we'll speak of in a minute. But we've just done some research, and we already knew this. It's confirmatory research, where we looked at safety investigation reports, complaints reports, which were published by organisations whose sole purpose in healthcare is to share and promote learning. And so these reports are out in the public domain, supposed to be good practice in how we learn from significant complaints or significant events, some of them high profile in the media and well known to all of us. But when you actually critically examine these investigation and complaints reports, we find multiple examples of direct and indirect blame of people, of teams, of departments, of individuals and organisations. And so it highlights to me, and certainly to my colleagues, that there's a significant learning need there. And I suspect we don't even know that we're doing it half the time, because it just becomes, I think it's just a natural part of the human psyche in terms of how we think and how we write. And so that has an impact, because I know from my work in Scotland, especially in general practice, that I can talk freely here, I would imagine. So our ombudsman in Scotland, when he and she publishes complaints reports in the public domain about maybe something that's happened with a patient, often the GP team gets it in the neck. They get a right good kicking as a result of these complaints, and the GP teams are always furious about it. They don't take it seriously, and so it's counterproductive. And so this points to this foundational idea that you cannot blame and learn at the same time. And I think that we're actually very good at that, and we need to unlearn that type of practice. So avoid blaming individuals is a foundational systems thinking principle. Now, this SEEPS framework that Helen's introduced, and which we'll learn a lot more about, especially as we're actually badging it as the kind of Swiss Army knife of human factors. It has a multifunctional purpose, and one of the purposes is in learning from when things go wrong. Either at the team-based level, so you can have a team-based meeting around that, or at the organisational level, we tend to do a kind of safety investigation, a typical root cause analysis, or whatever the case may be, over a number of weeks and months. And so we recognise that safety incidents are always caused by multiple interacting contributory factors from across the care system, and are very, very, very rarely down to the actions or the inactions or the behaviours of single individuals. Okay, so that's again a foundational principle. And if you remember earlier on about the human factors principle of, you know, if something goes wrong, an error has occurred, then we see that as a systemic issue rather than a failing on the part of an individual. And on that note, we consider human error therefore to be a symptom of a system problem and not its cause. But quite often, in the work that I mentioned about the critical review of these investigation and complaints reports, we see a full stop after the cause was human error. You know, and when that is the point at which the investigation and the learning should start, we've actually ended it. And so that's, again, is not well known within healthcare. You know, there's huge variation there. There's some excellent practice, clearly, but by and large, I think we often fall into that trap of saying it was human failure and human error and just stopping there. And when we need to go and explore the systemic issues in a bit more detail. And so we adopt that systems approach. So that's related to the idea that things are caused by those contributory factors across the system. So we apply that systems analysis framework to the problem. So this is about looking at an event, but it could be looking at any type of safety issue in general. You know, it could be like, how do we design a safety intervention, or in any type of improvement intervention? We take a systemic approach to it. We don't just think about, you know, the people involved in the intervention and how they're going to use that particular intervention. We consider how when the intervention hits the front line, what it's going to interact with, what can potentially lead to unintended consequences. You know, what could be a barrier to progress here? And so we think more broadly about the organizational issues. Is it going to interact with technology? Is it going to interact with, you know, somebody doing a highly complex task? Is it going to interact with people in a specific context, whether that's working at night or working during an emergency or just everyday routine work? You have to think through these different issues in order to get a proper, more meaningful understanding. So hopefully, I don't know how many of you have heard this term before, but this is hopefully something that you go away with. If there's one thing, arguably, that we would like you to go away with, it's the understanding of these concepts here. Work is imagined and work is done. Now, as pharmacists, I'm pretty sure you'll be very strong on the need for standing operating procedures and such like protocols and work procedures. And we fully understand that. But what we're asking you to do is to think critically about, are they always properly, adequately designed? Are they always fit for purpose? Do they reflect the work as it's really done? Or do they reflect an idealized version of what you would like to see happen, but rarely ever get to that stage? So if we think about, very complex hospital situations, there are lots of different guidelines and policies and protocols which govern how the work could be done from a best practice point of view. But when you speak to the staff and you observe them on a daily basis, you see that best practice is impossible to deliver reliably in the way that's imagined, because the work is done in reality is completely different. You're 2 staff down, you don't have all the resources to hand, there's a demand capacity mismatch that you're having to deal with, you're overflowing with patients. You cannot practice the way that the protocol necessarily insists you practice, what the gold standard might be. You have conflicting goals, and you may have conflicting goals as well. So maybe the Department of Health in Northern Ireland is saying to you, you must be safe. We want pharmacy to be safe as possible. And that's a goal, that's a worthy goal to go for. But on the other hand, they may have some sort of efficiency campaign on. They're asking you to be efficient at the same time. So these two things are often cause a tension, what we call a conflicting goal. It's very difficult. You have to trade off sometimes between safety and efficiency. So if you think, for example, a GP surgery, the GP's got 20 patients sitting outside. Typically, they've got 10 minutes to see each patient. Typically, each patient comes in with 6 or 7 problems. You need to try and resolve these issues, or at least safety net, within 10 minutes. And I'm pretty sure you've got your own analogous situations here in pharmacy. So that GP has to think through, right, I need to be as safe as possible. I can't be as safe as I would like to be in managing this patient's clinical conditions, but I can safety net as best as possible because I need to be efficient. I've got another 19 patients to see today. So if you think of that situation and how you're always trading off thoroughness with efficiency, safety with efficiency, that's typical of having to adapt to work to get successful outcomes in highly complex care systems, hugely demanding care systems. And you guys will see that as part of your routine work, and you would have seen it much more so as well during the COVID period, and we're still basically coming out of that. So the idea of understanding work as imagined and work as done. So work as imagined is what's often enshrined in policies and guidelines, what's often enshrined in the minds of those who don't do sharp end work. So they might have used to do it, they might now be in policy positions, they might be in leadership positions removed from frontline, they might write guidelines, but they don't do the work. Okay, as I say, they might have used to, so they've got some understanding, but you know the everyday reality of it. And so what we're trying to do here is understand both worlds and try and bring them together. So for example, if a standard operating procedure is not well used, or is only partly used, or is never used, then that, but people feel there is a need for it, then that's a red flag that we've not reconciled the worlds of work as imagined as work is done. So the reason it's not being used is it's not usable, it's not fit for purpose. So if we want it to be helpful, then it needs to be designed in a way that it reflects how the work is done in reality, rather than what the gold standard actually says. I know that might jar for some folks, but that's the reality of working in highly complex systems. And that's a foundational principle, again, that we need to understand and potentially embrace, because we cannot have this idealized world that perhaps the media and the public think should exist, and some of us think should exist as well. So that's something we could potentially debate later. When things go wrong, and this again is what we find in a lot of our thinking and a lot of our investigation and complaints reports, in the way that maybe we approach team meetings and with a view to learning, is when we think about something going wrong, and you think about somebody 3 weeks ago who should have done something or could have done something, and you hear about it and you roll your eyes and think, who in their right mind would have done that or didn't do that, and just shake your head in disbelief. Okay, that's you falling into what is known as the counterfactual trap. So you haven't explored that person's local rationality, because that person is likely to be as qualified and trained, as experienced as you as a pharmacist. But they made a decision, okay, or the team made a decision or took an action 3 weeks ago, 3 months ago, which at the time made sense to them. Because do you know why it made sense to them? Because otherwise they wouldn't have made that decision or taken that action. So what we often do, and this is a hindsight bias, is make a retrospective judgment on it by saying, well, they could have or they should have done something. And that's not learning. That's falling into a counterfactual trap. That is an alternative universe because it didn't happen. What we're trying to do is understand the context and the situation that the people in the system faced at the time, because that's what forced their hand to make the decision or take the action that they did. And that's where the learning is. And that's known as exploring their local rationality at the time. And these are concepts that are not well known in healthcare. And as I say, we found multiple examples of both the failure to explore local rationality in investigation reports and plenty of examples of counterfactuals. Investigation reports where it's boldly stated that a team should have done something or could have done something, with no explanation as to how and why they didn't do it. Okay, so these are two really important concepts, not just for investigations and when things go wrong, but for everyday thinking about the nature of safety in these complex clinical situations that we find ourselves in. I spoke already about trade-offs and adaptations and what we call performance variability. So you guys do that minute by minute every day. You are trading off and adapting to the situation you see at hand. So safety doesn't reside in your standard operating procedure or in your computer system or in your brilliant skill as a clinician. It resides in all these system elements interacting together. And most of the time, that gives rise to successful outcomes that we're trying to achieve. But occasionally, we get outcomes, unwanted outcomes, clearly, that we don't want to see happen. But by and large, in complex systems, because of the nature of them, it's people like yourself, your adaptability, your creativity, your professionalism that provides everyday success. Okay, and that is a characteristic. That's an attribute only that you find in highly complex systems, which are hugely people dependent. These issues are not well recognised. we still think they should have just followed the bloody protocol, or they should have just followed the checklist, or done X, Y, and Z, and everything would have been hunky-dory. That's not the reality, unfortunately, folks. That's a different reality. These tools are helpful and they're necessary, but they're not the answer. It's the combination of issues which are ongoing here, as Helen had pointed out earlier on. So I think we're going to pass on to Helen just now to talk a wee bit more about SEEPs and about performance influencing factors, but possibly take 2 minutes before then to maybe answer any questions that are in the chat, and what I had to say about systems thinking principles. Anybody want to challenge anything? Anybody want to share any experiences? Anybody want to throw some rocks at us?
I think there was a good question there from Julie, Paul, but I didn't know if we're going to cover that when we start talking about the resources at the end,
Right.
where Julie was saying about basically how, when everyone's really busy, how do you create the time for capturing team perspectives? So I don't know if you want to address that now, or leave that till we do the resources at the end.
Well, it's a really important point. So when I'm looking at it from an organisational perspective, and I appreciate most of my work recently has been in hospitals, and I've been speaking to people in executive positions and non-executive positions. I'm saying that they're asking me, well, what these system thinking principles, what do I do with them? I say, well, your job is to create the conditions for the clinical teams to flourish and to try and enhance their performance. And so what does that translate into? That translates into, one example perhaps, you make sure as best as possible, can't be perfect with it, but as best as possible, they have protected time for team learning. And I think that plays into the issue. So that's something that an organisation can create the conditions for in some way. I know it's pretty different. I know there'll be huge variation there. I know that there's resource issues, there's pressure issues, but by and large, that's one example of what we call a leading indicator of system safety, is that teams have at least some time that's protected, that they can reflect on their own practice and learn from it and seek those multiple perspectives. I'm sure some of you are rolling your eyes maybe there and saying that it's just not possible in our current conditions. I absolutely get that, because there's going to be huge variation across the service and in terms of those teams that are able to access that protected learning time and others who just cannot get a catch chance in hell.
Yeah, and I think it's sort of fair to say as well, it is dead easy for us to say that, sort of sitting on this side of it. Right. But it's one of the things that kind of does, I suppose, need to be flagged up when people don't have the time to do things. That in itself obviously is a performance influencing factor. One of the things that we're kind of going to think about.
Absolutely. Sorry, very quickly, Helen. Philip's hit the nail on the head there. It's difficult in a busy environment when protected time is a luxury. So that's a cultural issue, Philip. You're absolutely spot on, and I've got every sympathy with you there. So the cultural element there is that from a national policy point of view, from an organisational leadership point of view, their job from a safety perspective is to make protected time routine rather than a luxury, to create the conditions where it's more likely to be a routine activity rather than a luxurious activity. And I appreciate that you will find that very, very difficult, to influence because of the huge pressures that you're under. But that's, safety is a shared responsibility of what we call all the system actors, and so their responsibility in that regard is for those who are higher up the hierarchy to create those conditions as such. And that's not to blame them. That's just to point out that's what their role is, or it could be their role.
Yeah, and I think it's worth, I have this problem from an education point of view, is that we say human factors is the way to improve safety. So you go to somebody who's in charge of the curriculum and you say, I want to teach them about human factors. And they say, well, we've got a really packed curriculum, what are we going to take out? And I'm always kind of reminded of that joke, where the guy goes into a pub and he says he wants 7 pints of beer, 2 gin and tonics, 3 packets of crisps. And then the barman says, would you like a tray? And he goes, God, no, I've got more than enough to carry as it is. Yeah. In many ways, as if you've got to learn about work and you've got to do work. If you can apply those principles in learning about work and doing work, then there's obviously a time cost at the beginning while you kind of embed it. But if it comes part of practice, then theoretically it should give you benefits.
So very quickly on that one, I wind up chief execs now and again, just trying to be funny with them, but hopefully in a nice way, because they always, if a BBC reporter sticks a microphone under the nose of a chief exec of an NHS trust and and says to he or she, you know, what's your number one priority, they'll immediately say patient safety. But to me, that's a rhetoric over reality debate. You know, to me, patient safety, they might think it and they utterly believe that patient safety is a number one priority. But the reality is, it's balancing the books is their number one priority. Although they would, you know, that never comes to mind to them, nor would they say it in public. I don't think. And so they'll argue with me. No, patient safety is our number one priority. And then I'll hit them back by saying, how many staff do you have in your patient safety department, and why? And I says, well, you've got 6. How many do you have in your finance department? And I said, well, I've got 126. You know, so that's where the mismatch is in terms of those outcomes that human factors looks at. So finance is much more of a significant outcome than system safety is, even though the system safety and the things that go wrong, which is arguably the biggest financial problem that we have. So that's a kind of mismatch in our thinking into how we can support these activities. I'm obviously going to go and say that because I'm a human factors specialist and interested in patient safety. So on that note, I will be quiet. Back to you, Helen. Thanks.
I don't think so, Paul. I don't think you'll ever be quiet. Right. So this next bit, we'd kind of like a bit of input but I just want to explain to you what we're talking about when we talk about performance influencing factors. So far, we will go over this again, I promise, for those of you who'll be involved in the later stages of this when we look at SEEPs in more detail. But I talked about the interactions and the importance of identifying critical interactions. So if I interact with a tool, tool or a piece of equipment, let's just call it a piece of equipment, then yes, there's an interaction between me and a piece of equipment, but that in itself is not remotely useful for you. You might be able to see that I'm struggling to do something, but unless you can actually define what it is, then you won't really have any more information for changing things. So it's not the entities that interact, it's factors pertaining to those entities. So an example, manual measurement of blood pressure. I don't know how many of you remember learning how to do that back at university. It's really, really hard work and students really struggle with it. And it's because the equipment is beautifully designed for picking up the physiological events of systole and diastole, but it's very poorly designed for the person who's actually got to manipulate it. And we kind of recognize that, and the design intervention is an electronic SFIG. But actually the manual SFIG, and in fact the mercury manual SFIG, is still the gold standard when it comes to measuring blood pressure. So you have to think about what you lose when you make these trade-offs. But so I know it's the design of the SFIG that's the problem, but does that really help me anymore in trying to improve it? So if I look at it in more detail, I might be able to find out exactly what it is. And for example, I've done a huge amount of work around this and found that one of the issues is actually fitting the cuff in. For novice blood pressure measurers, about a third of them will fit the cuff the wrong way around. And if you look more deeply into that, it's the design of the cuff. So very often the information that's printed on the cuff that's supposed to help you isn't actually very clear. People don't understand that. It's not been user tested to see if people interpret it correctly. But secondly, we have an issue of standardization. So if an organization has every single piece of equipment has a different cuff on it, then you don't learn those benefits of standardization. So do you see how by digging a bit deeper and actually finding out what it is that's causing the problem, we have more information for making recommendations. And these sort of things are what we might call performance influencing factors when you actually find out this detail. So for example, you might recognize there's a problem with the temperature in the place that you're working. Is it too hot or is it too cold? Is it too humid? All of those things that might impact on how people work. And we call these performance influencing factors. So these factors that interact are really quite important to understand. And we can look at those performance influencing factors across the different parts of the SEEP system, which is something we're going to do in the next few slides. Thank you, Paul. Sorry. Right. So what we're going to do now is just trying to get you to think about some of these performance influencing factors in relation to the SEEPs heading. So on the next slide, we've basically got the sort of blank worksheet, if you like, for SEEPs. And so on the left-hand side, all we've got there is boxes for you to put performance influencing factors in relating to the different parts of your own work systems. And so what we're going to do is just work through the different sections now. And if you want to pop in the chat things that you think might be performance influencing factors in your own work systems in community pharmacy. So do you want to so Paul?
Yeah. So just to get in there, folks, sorry. So this is one of the tools you'll go away with. This is just a blank worksheet for it's a multifunctional purpose. It can be used to analyse an event, or it can be used to design a safety intervention. I think the bit we're asking now is that, and this is the back sheet of it, it gives you some clues as to performance influencing factors around the different system elements of SEEPs, which we've been through already. I think what we're asking now is that in the chat, and we'll go through it systemic element by element, is what system-wide priority issues impact on pharmacy team performance and patient safety. What comes immediately to your mind? And so we'll start off with those performance influencing factors around tools and technology. So we could just take a minute or two and we'll give you some descriptors here. Well, what do you mean by tools and technology? It's to do with their design, their usability, where they're positioned in the practice. Do you have it? Is it accessible? Are they mobile? Does the barcoding work or not? So from a tools and technology perspective, what do you think is a priority issue that can impact on your own performance and on safety in general? And so just take a minute or so, whatever comes to mind, just pop it in the chat. So one word, a sentence or two, multiple issues, just fire away, and we'll collate these at the end. Feel free to name specific systems if that's the case, or specific pieces of equipment. Okay, thanks, Catherine. So the scanner's not working, barcode's missing, and prescriptions so unable to scan. So the drop-down lists are not always happened. Peer connectivity and communication with our stakeholders, yeah. The barcode won't scan. So suboptimal design of the software. It's a fairly typical one as well, unfortunately. Oh, that's a really good one, Daniel. Yep. So workstations not being adjustable for height. Storage issues, fridges. Yep, Angela's posing a question there. So anything at all, think through what irritates the hell out of you to do with tools and technology that you use, which by implication can have such a negative impact. Poor lighting as well, that's an interesting one, Alan, thanks. Catherine's hit the nail on the head again there. Some software doesn't seem to be designed by those who actually use it. You know, so that goes to you know, the lack of human factors input. We always take an inclusive design, a user-tested design. Philip's saying not enough space, essentially, I would imagine there. So it's great to see these examples of issues, you know, across the system that are related to the tools and technology as such. So we'll move on then very quickly. What comes to mind when we think about the types of tasks that you perform, you know, routinely on a daily basis? So some of them might be complex, some of them might be quite hazardous in nature, may take a lot of time to do. You maybe problematic if you're interrupted. Again, what frustrates, irritates, causes problems for you in terms which are related to tasks, and it could potentially impact on your own performance or the performance of your colleagues, and ultimately impact on either patient safety or your own well-being. If anybody wants to put their hand up and come on camera as well, please do so. As you want to explain something a wee bit more detail, feel free to do so. Philip said about multitasking, so the workload situation. An unplanned nature of work patterns, yeah, interesting. Haven't heard that one before, thank you. Yeah, the bugbear of many, Eunice, is the duplicate entry of information into more than one system. Which is probably hugely frustrating, I would imagine, and time consuming.
There was something that quite interesting I observed when I was doing a piece of work in community pharmacy was actually the person who was the responsible pharmacist, because while they were doing their own tasks, they were also, it was like they were kind of keeping an eye on what everyone else was doing at the same time and kind of trying to listen to about 10 conversations at the same time,
Yeah.
which is something I hadn't expected at all.
So Daniel spoke about the manual nature of tasks. So the implication, I assume, Daniel, is that some of them could be automated in some way. That's interesting, Tracy, about interruptions. So the evidence about distractions and interruptions is actually quite interesting. Not specifically around community pharmacy, but in healthcare in general. Because of the nature of really busy, dynamic, complex healthcare systems, it's often thought that while interruptions and distractions can be a pain, and they will be in your situation there, they're often sometimes quite necessary in order for the work to carry on as normal in another part of the system. So you may have, information that's really critical to somebody else quickly to get work done in another situation, or you may have to make a decision about a patient or a situation that's really important and has to be done quickly. So there's it's a double-edged sword, and we're now finding out in terms of the evidence about interruptions and distractions, which is quite interesting. The assumption has always been that we need to minimize all interruptions and distractions, but it's now around how do we minimize unnecessary interruptions and distractions as best as possible. There's a recognition that sometimes they have to be necessary given the nature of complex care delivery. You may not be convinced by that, but that's what the evidence is suggesting. Julie, no proper rest breaks. Yep. Good one. Philip's saying about despite all the automation, there's still a bottleneck of manual inputs. So I did a lot of work in general practice in their test results handling systems, which are they are either fully automated, fully manual, depending on what practice you're in. Things maybe have moved on because this was a number of years ago, or they're a mix. And the greatest risks are where there's a mix of automation and manual-based systems working to the same common end. I'm wondering if that's pretty similar in some circumstances to what you guys experience and face in community pharmacy. So demand from patients to be seen immediately. Thanks, Carson. That's really interesting in this about the need to provide training to others while it's also having simultaneously to deliver services as well. So let's think about the physical environment then. So some of you have already touched on aspects of this, but so don't know whether layout's an issue. Heard a bit about lighting, temperature, the air quality, the idea of clutter, a lack of standardization or crowding. So Philip's pointing out I assume another unintended consequence of the implications of COVID is that because the patients can't get access to other services, you guys are the go-to kings now, or wizards. So you might want to burst some of my assumptions here, because I was under the impression, just by observation when I go into pharmacy, that I'm always really impressed by the physical layout and the standardization and the lack of clutter. You know, the orderly presence of pharmacy and the easy accessibility of specific drugs. I work on that assumption. Is that generally correct, or is it an illusion? It's quite often what we're trying to impart to the rest of the care services is that in some specific circumstances, standardization and simplification can be really, really helpful to them. And that's why I tend to see when I go into a pharmacy. Okay, so we're now saying that stock levels have overtaken the physical size of the workspace. So there is a lack of workspace, lack of floor space. So yeah, so there's this growing reality that there's an increasing amount of products now in terms of stock, which is outpacing the available workspace. Yeah, that's an interesting one. So a large delivery arises during busy spells, which obviously interrupts workflow, maybe causes frustrations, impacts on the patient experience as well, I would imagine, because things have now slowed up. So there's noise implications, thanks, Alan. So there's actual drug shortages as well. Okay, so from an aesthetics point of view, Julie, I assume that's what you mean. There's more resources being, applied to that rather than the actual design of the workspaces. The bigger fridges and safes. Excellent. So moving on. So this is the kind of big area, like, well, let's talk about the person factors to come. So the organisation of work. So that could be team working, work schedules, the culture in a practice, leadership and supervision, communication, how you're paid, what your priorities are, any targets that you're given, hierarchy, education, training and development or lack of. So while you're typing up some of those examples there, one of the reasons for doing this piece of work is if we do even a very brief short report, a 2-pager on it, but we'll theme some of these issues. I mean, in order to raise awareness across the care system, so to those in leadership and policy positions, these are examples of factors that influence your performance every day, some of which are potentially resolvable by reprioritizing resource, perhaps. Some of them can influence what resources are released in future, and may point to the need for, maybe larger premises or bigger workspaces, and kind of more capital projects there, which would minimise risks ultimately, because we're accommodating the need to enhance performance in these areas. Because currently, what you're highlighting are issues that degrade your performance. Yeah, so the whole issue around CPD, protected time, you guys have probably done a busy 10-hour plus shift today, and then you're on here having to listen to this Glaswegian warbling on about human factors for 2 hours, when really what you want is your dinner and your bed. So that's not an ideal, ultimately, learning environment. So we've got a recruitment and retention problem as well, poor pay, doesn't reflect what you're doing in everyday work as well in terms of reward there. These are things I was unaware of, so it's fascinating, Carson. Thanks. Pharmacy contracts. Okay, so you can feel free to keep typing these organisational issues. So the contracts, maybe. Oh, sorry, as you posted that, Helen, that's potentially an external issue. So what external factors? So what's the government doing? What's the regulator doing? What's your professional body doing? What are national policy and targets doing that are impacting on how you do your work, that are degrading potentially your performance, or at least impacting on that performance? And it's causing you frustration, it's causing you problems, challenges, irritations, and that potentially can have an impact, as we've said, on safe care, as well as your own well-being. Is there legislation that's influencing what you're doing? So we see two classics recently of external factors. So certainly in England, I don't know if it's the same in Northern Ireland. We see the 4-hour, I know it's been done away with now, the 4-hour wait target in A&E. So staff are working under huge pressure in demanding situations in an emergency department, and they've always got one eye on that 4-hour target. So it's definitely influencing how they work, how they prioritise their work. We don't know whether it's influencing performance to a good degree or otherwise. Similarly, in your GP colleagues who were paid in a pay for performance model on 16 chronic disease conditions. It's still the case in England, I believe. It's been done away with in Scotland, I think. And so they were paid for raising the quality of care across 16 chronic care conditions, patients in those groups, and they maximised their income there. And that was good for those patients. But it had an unintended consequence, because if you were in a patient group that didn't fall under any of those 16 areas, then the evidence is now suggesting that you were given less quality of care as such, because the GP team's priorities were drawn towards maximising their income to do with the contract. Inflationary pressures, drug shortages, fantastic examples. Design of medication and packaging. Yep, thanks very much, Angela. And then finally, person factors. So what is it about the patients you see in terms of their capabilities, their limitations, whether it's physical or psychological or cognitive issues? Apply that to the workforce, knowledge and attitudes, risk perceptions, and so on and so forth. What comes to mind immediately here? Quotas. Philip, can you type? I'm unclear what that is. Philip, do you mind typing in a wee bit more explanation as to what you mean by quotas? I'm sure that just by reading the media. Sorry, right, okay, Philip. Yeah, thank you. That we had some horrendous stories of pharmacists and pharmacies being put under significant pressure by demanding patients, and Stephen's just posted that. Yeah. Excellent, Ines. Yeah. I want it now. Polypharmacy element, absolutely. So we're seeing older patients, multiple morbidity, but then polypharmacy. I'm assuming we're seeing, not that I'm trying to put ideas in your head here, but I'm seeing staff who are more fatigued, more frustrated, more stressed out, potentially leading to burnout. Don't know if anybody's got any personal or experience of that in their own practices or are aware of what's happening elsewhere. Right. The lack of accessibility to GP practice, Catherine, interesting as well. Okay, that's excellent. I think we've got enough. I mean, just feel free, anything that comes to your mind for the rest of the session, just post it in the chat and we'll theme it. And so, you know, we'll report back to you in some way using the systems analysis tool, the issues that have been picked up here. I'm assuming they'll be of some interest to those in the profession and also to those in leadership and policy positions. Late diagnosis, Julie, that's an excellent one as well. Thank you very much. So, Helen, we got 15 minutes left, well, 10 minutes left because we wanted to at least have 5 minutes for a discussion. I won't go into safety culture. I was going to speak about safety culture, but I'll go straight to, we may come back to the safety culture element of it, but I'll go straight to some of the practical concepts and methods that we will send to you, which we think, well, we know you'll be able to engage with because we've already tested them with lots of other clinical professions over a number of years. And so, but it's just to raise awareness of them and the potential usefulness of them. Now, that's being said, the issue that's been raised here is potentially the protected time to actually engage with some of it and apply it. So we appreciate that there'll be huge stressors in that regard, but at least you are aware of some of the concepts. So we've outlined to you a set of principles, I think some of which I hope you would understand could be useful to you in the way you think about safety, and the way you approach things going wrong, and the way you may think about extracting learning and to inform improvement locally in your practice. So these principles, to some extent, we think are useful to practice. We're going to give you this worksheet anyway, because in future sessions, you'll be introduced to it in more detail, as Helen's already said, and we'll unpack it. You know, it's a very basic, generic worksheet, which can be used for a whole host of different issues, including looking back at events or planning improvement interventions or designing a standard operating procedure. You know, the worksheets themselves go like hotcakes. They're very well known, certainly in the areas that Helen and I work in, and folk engage with them quite readily and use them for a whole variety of different uses. For example, in going to leaders in the service and telling a system story, using that as a visual about what the issues are that they need to know about. Because quite often when we try and brainstorm as a group, or we try and tell a system story, we think about it in general terms, and we focus maybe on the people issues and maybe some of the technology issues. But this lets us have a much more holistic understanding, and if you visualize that, it lets people see the bigger picture. When you are saying we need more resource in an area, or this is the problems that we're finding in a specific area, or locally, this is what we can do together as a team, and we can set it out. So typically you would, you know, maybe brainstorm in an unstructured way, and you might not think of all these different elements. You might think of some of them, but not all of them. But now we're giving you a structure to brainstorm and think and problem solve in that regard. And that's what the feedback has been. It gives you a more meaningful, holistic perspective on whatever the challenges and issues are you're dealing with. Safety culture discussion cards, we're going to send you a PDF on to these and hopefully arrange some packs for those of you who want to use them in the future. Again, these go like hotcakes across the UK and internationally. It's something I was involved in a number of years ago. I know one or two of you may be familiar with them already. Again, it's another protected learning time issue, although they can be used for 5 or 10 minutes. And there's multiple ways these cards can be used to discuss, like care teams discuss safety culture elements. But you know, you could use them as part of a protected learning time meeting. I know that's difficult, but they can be used as part of a brief or a debrief situation as well. We spoke about the design of work procedures. There are core principles from a human factors perspective that can help us to design or better design standard operating procedures or checklists or protocols that are more usable, more likely to be embedded in practice, and more likely to be useful. So we see, for example, that operating procedures are cited in around 80% of patient safety incidents, according to the evidence base, as being a significant contributory factor as to how and why something has gone wrong. And quite often it's to do with a suboptimal design. A big issue for me, working with different clinical professions, is that you're not taught at undergraduate level or postgraduate training how to develop, co-design, test, implement and evaluate standard operating procedures. The assumption is that you can just come in and pick it up, or somebody else will teach you how to do it, or you just work as a group and do it together. I'm sure there's good examples there, but I'm sure they could, many more could be a lot better if we understood the key design principles, which make them potentially much more usable and useful. A piece of work we did in lockdown and COVID and general medical practice, again using the SEEPS framework, was to come up with a risk assessment framework for general medical practices as remobilised during COVID. Now, the COVID element of it we can take out, but the idea of using the SEEPS framework to do a risk assessment in your premises, or in any type of looking at any sort of process, any sort of care process or work process, is potentially useful. So we can provide you with that. I don't know what your approach to proactive risk assessment in pharmacy. It may be more advanced than what they do in a general medical practice, in which case fantastic. But the GP teams are, I would suggest, light years behind other areas in healthcare. But anyway, we can let you see that, and it's something that you could potentially adapt in terms of doing a proactive risk assessment, and also combine it with what we call a walkthrough analysis, which is just a very simple technique of using the SEEPS framework to walk through a practice, walk through a situation, and try and proactively identify risks by speaking to people and observing what's going on, and so on and so forth. This is a basic human factors technique that any specialist would know about and we use quite often. And this is something we can speak to those who have an educational leadership role. We've got lots of education and training outputs around human factors from e-learning, from different courses, which are more than happy as part of our UK network to share with colleagues in Northern Ireland for them to adapt and potentially offer as part of future CPD for yourselves, or as part of any routine education and training that you may wish to run nationally. So lots of stuff there. Pretty sure most of it won't be gobbledygook to you. It would need to be unpacked. But again, that's something that we can discuss with Angela and other colleagues as well going forward. So we've got 10 minutes left. Hopefully that's enough time for anybody to ask any questions, make any comments, highlight any challenges for us. More than happy. What would be absolutely wonderful is somebody stuck their head above the parapet and actually come on camera, spoke to us. So is there any clarifications, any questions anybody would want to ask? So just in the last one. Philip, are you saying okay, you would like to come on?
Yeah.
Oh, good man.
I'm down with a cold here at the minute, so bear with me.
No,
I think community pharmacy is a unique and working environment, and I've worked in quite a few different places, and every pharmacy is different. But I think the key issue with community pharmacy is that we're all very accessible to people. Sometimes we're too accessible, and that sort of impacts on our sort of efficiency. What we can get done. I've seen myself, stand behind work many a night and doing stuff in a third of the time, rather than trying to get things done during the day with the telephone interruptions, with the people interruptions, and sort of dare you make eye contact with the patient because you're the only sort of accessible sort of healthcare professional that person may have for the next 9 months with the way things are. So difficulty. I'm not blaming anybody. I'm just saying that's That's just the pressures that the system is under. People trying to get access to their GPs, trying to get access to consultants. I've seen this professionally, I've seen this personally. It's just so difficult to try and get sort of effective treatment plans in place. And unless you sort of really sort of push the boat out and stamp your feet a lot, it's difficult to get something that's effective. But we do work very well. We're all very resilient. But it would be nice to see that we would get what I sort of said, that the luxury of protected time. A bit of protected time with your pharmacy team would be it would be a luxury, and I know it's something that we should just try and implement and try and put into the normal working day. But it's difficult whenever you're opening, at a certain time, and you're just open door to the public all the time.
Yeah.
I'm trying telling a member of the public that I'm trying to have like a staff meeting here. We're trying to sort of do some sort of training here. Whenever they're double parked outside with 3 kids screaming in the car, and the dog has to go to the vets. Those are the real sort of things that you're dealing with, in the pharmacy. But we do try and sort of get time to train staff, to try and sort of give them some sort of direction, incentivize them, and sort of keep the spirits up. But it is difficult, under the circumstances when we're all sort of working under all those pressures.
Yeah.
And I think I made reference to it before that we're working under pressures that have been sort of thrust upon us by other sort of denominations, and it's difficult to sort of try and to keep the whole sort of the system going, spinning plates, keeping the workplace safe, keeping it cost effective, and making it work so it can continue. So there's a lot of different sort of influences going on there that I'm sure many of us can associate with.
Well, thanks very much, Philip, for sharing that, because part of what we interpret from complexity science or from systems thinking, in which healthcare is arguably the most complex workplaces that have ever existed, is everything you just described there, and that's what policy leads and those politicians and the public need to know, is that under all those conditions you've just described there, it's you guys that enhance your own performance, that create safety, that adapt to the situation and the context that you find. Now, don't get me wrong, sometimes some of you fall by the wayside because of the sheer nature of what you have to deal with, but by and large, that's what many healthcare staff are doing. They rise to these challenges. It becomes routine, it becomes normal, and it's unfair largely because you are continuously achieve this success under these suboptimal conditions. And then, of course, when it sometimes goes wrong, who gets kicked in the head? It's often yourselves, yeah. So and this is the point we're trying to get across to those in leadership and policy positions. To try and share your world with them in that respect. I'm really interested to know. Is it to do with your contractual arrangements as to why you have limited or no protected learning time, but in general medical practice they tend to get some access to protected learning time? Is this just because it's a negotiation issue around contracts?
I don't know what what way that works. The general practice getting protected time. I just know they get protected time. There's like a practice-based learning or something like that. I think they call it. And it's basically the doors are closed. And I don't know what happens in practice-based learning, that they just they all sit together and congregate and talk about everything from A to Z. And community pharmacy has always been sort of trying to fight for 10 minutes here, 10 minutes there.
Yeah.
By the way, there's somebody on the phone there needs to speak to you now. Somebody's walking into the pharmacy with their arm hanging off. Because they can't go into A&E. Everything's just thrown upon you. When somebody just said, Anita just said there, about the minor injuries unit, it's almost like, you feel as if you're in ER, sometimes,
Yeah,
you know.
and somebody's Anita's posted that comment.
Aye,
Yeah, sometimes it feels like
stopping at 21 marks are still in there, and you know, and
Yeah.
this we perform open heart surgery here.
Fantastic.
You know, I had people coming into me, you know, I've been to the GP, I've been to a private consultant, I've been to the hospital twice, and then they come in and say, look, can you do anything?
Aye.
You know,
I know. Yeah.
It's just the expectation that you're going to whip something out of your magic hat.
Yeah.
And you know,
it's an untenable. It's an untenable situation as well, ultimately.
Yeah.
Thanks very much, Phil. We've got 2 minutes left. I'm wondering, anybody else get any comments or any queries or clarifications, or does Angela, Julie, Fiona, have you got any comments at all? Observations?
I think, Paul, it's been a very good thing. I suppose I'm going to have to close up here to get everybody sort of done by 9, but it's been really, really good foundation for the next parts. You know, moving forward, this is, I think people described it at the start there as being complex, but hopefully you broke that down. It's probably will come together over the next webinar, and we'll move into that now when we go into those. So what will happen now is Julie's hopefully going to put up on display the details there of the law, how to register for the next webinar. And then another thing that's going to happen is we're going to get should happen hopefully on screen as well, a quick feedback from everybody. And if you could do that before you leave, we will send out a more detailed one by email to everybody, and the resources, some of those useful resources, we'll send that out. If you have your phone to hand there, point at that QR code and you will get the link immediately. We had a good number there. We had just over 40 on screen, and that'll probably be a good basis for the next workshop, because we're getting more down into the insulin and actually that's within the title, and we'll get more into that the next time. 40 will be a good number. However, we will also be putting out this as a recording. So it's encourage anybody who's on tonight to register as soon as they can, because when it's gone, it's gone. And Sharon, thanks very much. You've put that in there. So really now just to thank Paul, to thank Helen, to thank Sharon, particularly for facilitating the tech tonight. I think we'd be lost without her. And to thank Julie from the Pharmacy Forum, and of course Fiona and Angela as well for speaking there as well. And the next one is in 1 month's time, exactly 4 weeks time. And it is a building thing. If you can take away the tools, particularly the SEEPs tool, I know I'll be taking away the comments that were made in the chat box, and to get a better view of what's going on out there, and putting them in my own SEEPs tool. I know, Loretto, you had said the work imagined and the work done, you just put in the side best slide. And I think if I can take something away from that there, that's what we're thinking about in this here. It's about co-production. Julie said it's co-production, but it's a co-production with the Pharmacy Forum and SPPG and you guys as well out there. And I want to get away from that work as we imagine in our ivory towers to the work that's really done together, to come up with hopefully a very useful tool at the end of that, that can be spread, and not just for the people on this, but beyond this group. So thanks very much, everybody. Julie, have I covered everything there from the formalities, or?
Yeah, obviously we've referenced quite a number of things that we'd like people to have access to. So maybe over the next few days, Paul and Helen, you know, we can bring those resources together and then put them in one place so everyone can access them. So we will be in touch with you. You know, we'll immediately send out some information, but we'll then send out the slides and the link to that, and maybe some of the other resources sort of in the coming days. So just to let you know that we will work towards that. So maybe just Sharon.
Julie, the survey, did it pop up there?
Yeah, Sharon, do you want to start the little poll? If everybody wants to just fill in, and just if you scroll down, there's a number of questions there, just with quite quick tick box responses, and then when you got to the end of it, then hit the submit. So that'd be really useful for us, so thank you very much.
And we're done at 1 minute past 9, so once you get that, head off and have your supper. Thanks very much.